Thank you very much, Maurice, for this introduction, and very happy to be back in Dublin. As I recall, I was in Dublin for the last event before the COVID struck out. We presented the results of the IGS review, I think in March 2020, a few days, and everything broke after that. So I think the title of the sessions is Enablers and Constraints Required to Embed Evidence for Policy into Organizational Structures and Routine Practice. It's a slightly long title, but I understand it has to do with how and what are the implications for implementing evidence-informed policymaking in healthcare. And I must say, I come to these issues from a dual background. I'm both an official and economist, having worked at the OECD on many governance and projects over the time. But I've also worked for nearly 10 years of my life as a health economist. I'm not working in the health OECD division today. We have a whole team of 40 to 50 people. But I worked for 10 years in that area, both before joining OECD and during my time at the OECD, where I helped to establish the OECD Health Committee and several work streams that are now quite well developed in this area. The first thing is a quick reflection on the concept of evidence-informed policymaking in healthcare. Because evidence-informed policymaking can be defined as a process whereby multiple sources of information, including statistics, data, the best available research, evidence, and evaluations, are consulted before making a decision to plan, implement, and alter public policies, interventions, and programs. So evidence has to do with data, with science, but as was mentioned by Anastasia, we're only talking about evidence-informed and not evidence-based policymaking, because evidence is only one of the considerations that plays into policy decisions. Outside the world of science, you have what I call the messy world of politics, opinions. You know, my country is particularly fertile about opinion debates at the moment, and all of that has to feed into actual ministers' decisions and policy-making decisions. I would just make the case that in healthcare, I'm not sure I would argue that we are discussing more evidence-informed decision-making than evidence-informed policy-making, because the big choice is whether your system has to be private or public, or are largely ideological decisions that are not necessarily informed by pure science, whereas the realm for evidence-informed decision-making is very rich in healthcare, in how you develop health practices, where you have to direct your resources, how your system gets organized. And these features are very important in order to improve the outcomes and the final results and the sort of the value for citizens, the people who we never met, as was mentioned by your minister this morning. So just to frame the health sector, because I've worked with various sectors in my life, in fact, it's a very interesting sector because you have huge economic and social implications. There's actually a lot of money going into healthcare, and a lot of money means, as was mentioned this morning, very active lobbies, because behind every penny, every euro spent, there is a lobby, because a euro spent is an income for someone. This is often a major area of public expenditure for the people for whom I work now, budgeting officials, the people at Department of Public Expenditure and Reform. Health is seen as a big fiscal risk. Where is all our money going and what can we do with it? And there are also significant public attentions, because anytime there is a scandal in the hospital or someone dies or mistakes happen, this is very emotional, and citizens do care about their healthcare systems. The second characteristic, it's a peculiar international government activity, because it's what you would call a cottage industry. It's really a sector for which you have national prerogatives and national organizations, yet at the same time, it's super international. And how is it internationalized? I say that in that sense, Ireland might be a little bit unlucky, because the market for healthcare professionals is international, which means that Ireland has to compete with Americans or North American market rates, as many of its health professionals, when they're well qualified, can also go abroad. But also the scientific progress is also shared at the international level, which means that, and I will come back to this, I do think that there is a general technological progress in healthcare that is biased by the implicit economic incentives that are prevalent, particularly in the US healthcare systems, towards ever cost increasing technological progress. And this is kind of disseminated across all OECD countries, and European countries, particularly those with universal healthcare systems, are struggling to arbitrate trade-offs and decide how best to cope and how best to make sure that this technological progress is integrated in their systems. So somehow that's what I find very interesting, the very domestic nature of the field, the huge economic implications, and the fact that it's in fact an international activity. And within that, what is the scope for evidence-informed policymaking interventions? You can think about the assets. And in healthcare has been a pioneering field for the development of evaluation. The Cochrane groups are now 40, 50 years old. The activity, systematic reviews, this is something that does not exist to the same extent in other social fields. The second thing, it was mentioned, Ireland, in a sense, hugely benefits from the development of its Irish Government Economic Evaluation Service. When we did the review 4 or 5 years ago, I think the Ministry of Health, the Department of Health was expanding and establishing its analytical branch, and I can see that it has now flourished and is being fully established. And also, I would say the activities of health technology assessment. I think in Ireland, they are partly with the health executive and the health information quality agency, but it's a very important activity to make sure that you conduct evidence reviews or systematic reviews on how you want to use technologies in your system. And within that space, you have to see how you ensure good processes, tools, and methods, and how you somehow establish a role for knowledge brokerage. It was also striking to me this morning how I heard that Ireland at this stage has significant assets and supplies and qualified professionals, but may tend to rely a bit too much on informal networks. And I think that's both the privilege and the curse of a smaller country, because it means you always went to high school or a cousin or know someone, and these informal relationships are somehow making the relationships more fluid if you think about an ecosystem. But it also means that it's not structured, it's not organized, it's not transparent, it's not necessarily systematic. So this is not necessarily an ideal solution. So I also wanted to say, in relation to what my colleagues Anastasia was saying just before me on the links between evidence-informed policymaking and democracy, that in the OECD Trust Survey, we did find a very clear an econometrically proven relationship between the perception by citizens that governments were making their decisions based on evidence and actual trust in government. That's something that was a very clear result and a very clear achievement of the OECD 2023 Trust Survey. Now, if we go to healthcare, here I have presented to you the latest OECD performance assessment framework. It's a very political document. I'm not the author of this document. It was prepared by my colleagues in the health division. It somehow updates a previous framework that was prepared in 2015, and that framework was adopted or welcomed by OECD health ministers, I think, at a ministerial meeting in 2023. I think what's interesting here is that it really recognizes health outcomes at individual and population levels, as well as what you call the non-health determinants of health, for which the McMaster School has made a very significant contribution over the years, and we heard John Davis this morning, and also underlines the role of people's health needs and preferences. What is also noticeable is the explicit recognition of knowledge and innovation as part of the resources and inputs. You can't see it very well, but it's one of the blue rectangles below in the document. And you would say, so what? What's the use of such a framework? And in fact, the OECD uses this framework for two main purposes. First, it somehow provides us with a structured guide for the OECD flagship publication that my colleagues are doing on a bi-yearly basis called Health at a Glance. And for those of you who don't know necessarily the OECD, I mean, a quick word, we are an organization with 150 committees, 15 different directorates, and we cover about every field of government activity. And in every major activity of the OECD, we try to publish these at-a-glance publications. In my own field now, we have a government at a glance, there is environment at a glance, there is the pensions outlook, the economic outlook. So the health at a glance, this analytical framework somehow, I think, provides the analytics underpinning for the collection of data and indicators. It also provides an analytical framework to do policy analysis. OECD has done also reviews of health systems, and they can be informed by such a framework. So now going back to evidence-informed policymaking. From my OECD experience and working on this issue for the past 4 or 5 years at the OECD, you need 3 key elements to make evidence-informed policymaking happen. You need to have competencies and capacities, and you need governance and science for policy ecosystems, and you need to have capacity in the civil service and science for policy. I think as was highlighted this morning and throughout the discussions, Ireland has now, I would say, a lot of it, or is well equipped. And the health area is no exception. Across the departments, there are still some areas lagging behind from what I saw when we visited, and I don't think these gaps have easily closed up in 3 or 4 years, but at least it's making progress. You need tools and processes and options for public engagement. You have to have capacity to identify and frame the issues, talking to leaders and managing the risks of capture. And I will say a word about it because it also popped up in our OECD GRC Technical Support Instrument project. And you also need to invest in cognitive approaches. You need to take advantage of behavioral and cognitive approaches. And I saw this morning that you have apparently a team in the Department of Health that looks at this. And I think this was one of the main lessons from COVID, because you needed to integrate people's behaviors and understand people's attitudes to risk or attitudes to information. And you also need to identify areas for policy fragmentation and mis- and disinformation. And I guess all of you have seen all the debates about vaccines and preventive strategies in healthcare, though. From the outside, I must say, we have the impression that policy fragmentation is less extreme or not as high in Ireland as it can be in some other OECD countries. I'm now going to share with you some lessons from the project that we did jointly with the Joint Research Center, for which we also designed a specific framework of analysis. Some of the main lessons are the need to align institutions and behaviors to invest in relevant and impactful supply. That was maybe not something that would necessarily be necessary in Ireland, but for some of the smaller member states or Greece, that was relevant. Governance matters. You need to invest in organizations, and I think that will be very relevant probably for the future work with Ireland. And you also need to tackle systemic issues to strengthen trust. Now, going a bit more into the details, one of the across the findings, and we have a forthcoming project, a forthcoming report that is supposed to be published, because while the project was finished in March, due to our approval processes and some bureaucratic processes, the report, the joint OECD GRC report, is not yet fully out, but some of the key lessons. So the first one is to encourage clearly articulated policy problems and culture of inquiry. I think Ireland has IGs, and you have a set of economists, but if you look at more advanced systems like Canada, Ireland does not have systematic evidence plans across the various departments in Ireland, and they are not necessarily shared across the civil service. So I think from what my sense was that the organization was a bit fragmented. And however, Ireland also has a close connection between evaluation and spending reviews, and I'm sure that our colleagues from the Department of Health have a lot of pleasure in working with that, who is deeper every year. You also need to align incentives and strengthen feedback mechanisms. So you need to have effective science for policy funding schemes. And we found some agile and very interesting schemes in some of the countries, particularly Belgium. And you will be able to see that in the report, where they try to promote multidisciplinary funding and also to make sure that the funding schemes were also aligned with the department needs, with some form of client-based and co-funding approach. You also need to make sure that there is some acknowledgement of the contribution to policy within academic curricula. It's difficult because government is not managing universities, yet there is a need to ensure that for the work of academics, the contribution to policy and the contribution to the common good is somehow acknowledged. And again, among the countries, this was very interestingly the case, for example, in Belgium, particularly in Flemish universities, whereas, for example, in the Netherlands, the government was a bit complaining that universities were only teaching in English, publishing in key international journals, and were not necessarily sufficiently interested by the domestic policy needs of the government. And there is a Dutch report that was prepared by my GRC colleagues. You also need to make sure that you have access for academics to tendering processes for research and evaluation, that they are not necessarily captured by consulting firms. I think this is less an issue for the health area because I would assume the HRB funding is closely tied to Irish medical and public health infrastructure, but in some other policy fields, this can be a challenge. The second result of the project is the importance of knowledge brokerage. So not just making research happen, but making sure that research results are shared and do achieve impact and reach policymakers. And I think that I saw excellent materials throughout the conference already, so I don't need to go into too much detail, but our work underlined both the role of individual and organizational knowledge brokerage. The individual levels are the sort of people who are talking to ministers. In Ireland, this would be the Secretary General or the Assistant Secretaries in the Department of Health, the ones that have really to talk to policymakers. But at the organizational level, it's the role of organizations that are here to channel evidence. I'm not sure about the exact roles in Ireland, but we found some best practice examples in our project, particularly, I think, for Belgium, because we worked with Belgium. They have something called KCE, the Healthcare Knowledge Center, and also Sciences and the Netherlands have a very important public health organization called RIVM. And you need to make sure that knowledge brokers and advisory bodies focus on impact. That means they need to have active communication techniques. It's not just publishing a paper. Doing a 1,000-word summary is the minimum, because otherwise your paper can't be read, but also going on social media in a professional way, disseminating content, targeting your audiences. And also you need to make sure that knowledge brokers can communicate and coordinate with ministries. And you also need knowledge repositories and knowledge management tools, which I think can be a problem when, for example, for a smaller country like Ireland, immersed in a large English-speaking universe, how can you gather all the knowledge that would have been gathered and collected specifically for Ireland? Another important lesson was the promoting accessible, usable, and trustworthy evidence. So one issue was often the access and use of data, and I think Ireland has had a data strategy and has had some coordination with the Statistics Institute across the departments, though I am not sure that you already have systematic and fluid access to hospital or patient-linked data in Ireland for analytical and research purposes. This is often a tremendous challenge, has implications for the GDPR in Europe, and I saw many European countries struggling with that. You also need to promote misinformation and debunking efforts, which means that we saw that some statistical offices were ready to take on the challenge when they saw bad information out in the public domain. But I think this may require more active and more outward communication efforts from public authorities than was previously the case. And the last very important point is to promote integrity standards for researchers and senior executives. Because as we've mentioned, trust is key, but once you have broken the trust, or if people think, and that was the case in some countries during COVID, when members of the advisory bodies were found to also have research contracts with the pharmaceutical industry or with large companies, and people say, oh, but these doctors, they don't care about us, they just care about the money. And I think that is super important. And we had the example of the KCE in Belgium, where the head of the KCE and the managing directors have to have declarations of interest. But also these obligations extend to all the principal scientists and all the people who have their name on official reports. And I have not necessarily seen that practice to be so actively diffused. And I think I was very impressed by KCE in Belgium, because I heard this morning I think your former head of department, saying sometimes it's not easy for ministers to take decisions when the evidence is being promoted, or stopping a treatment, or saying no, that's not something that's so easy. But in Belgium, when KCE issues a report, and it's an institution with an impeccable reputation, and as you know, Belgium is a complex country, a fragmented country across linguistic barriers. They said within the next day, usually when we recommend something, our Minister van den Broeke takes a decision, and the next day the issue is resolved. And I know that this kind of fluid situation would be a dream for many other European countries. I know colleagues in other health agencies in Europe where they know that reports are out, and they gave, as an example, a report on the risks that were linked to smaller maternities, you know, the ones where you have fewer births every year and you don't have the same quality standards. And it may help as well that Van den Broeke himself is a very respected politician and a trained economist, but I thought that maybe some of the features, both the academic excellence and also the impeccable reputation of the center, is something that is super important to be able to justify these decisions in competence. Now, moving from that, so these were some results of the joint project with the GRC, the 7-country project. The second thing is, how can you actually implement and make evidence-informed decisions in healthcare? The first, I think, is to design evidence-informed strategies. I think there is a lot of to be said about the dissemination of strategies on breast screening, circulatory diseases, behavioral risks. And I will show you some data later that I think show that Ireland has made a tremendous progress over the years, because your results are now above those of some of your comparators, even very respectable ones, such as the United Kingdom. And you need to align the strategy focus with the latest research or systematic reviews, and there is scope for mobilizing AI. But since you invited excellent speakers in the morning, I don't need to say too much about that. But clearly, AI is a bit of a game changer, where you can now get systematic reviews in a much faster done in a much faster time than was the case before. And we had excellent practices shared with us from Norway in some of our networks. You also need to pool and network approaches at the international level. I heard John Lewis mention the International Commission of Evidence. There was also another try. There are two or three international efforts at the moment. There is something that is supported by the Wellcome Trust that has actually supported relatively wide networks. And there was also a global commission agenda with people like David Gruen, the chief statistician in Australia, David Halpern in the UK, who had also identified some of the current gaps, and we will be publishing an OECD paper report on randomized trials that we did jointly with the Australian Centers for Evaluation that actually offers you a bit of a mapping of these efforts. And you also need to move strategies towards implementation. The problem is, from all the OECD work on trust, we know that patients and citizens usually trust more the local police officer. They would surely trust more their GP than they trust the government, people in Dublin or people in Brussels. That would even be worse. So you need to make sure that the knowledge or the information is brought through local sources. And you also need to integrate research and cognitive aspects. And as I have mentioned as well, one of the challenges is to promote effective use of technology and healthcare resources where they deliver the highest returns to patients. And I'll say more to that, because from some of the first international studies I did over 25 years ago, I think this is a constant injections of new technologies, new treatments in healthcare. And as mentioned, a lot of the job of the health officials is to see where and how to apply those medicines given your national budget in a way that you achieve the results. The second thing, which I think is not so easy, is how to achieve evidence-informed clinical practices. And for me, in this area, Canada is an absolute leader. One of my best friend's wife has been a general practitioner, and they live in Hamilton, Ontario, and they are obsessed with evidence-based medicine. They follow the guidelines, they do apply the guidelines, they trust the guidelines. But I can tell you this is not the case in every country I know. And Canada and Australia are quite unique in this area. And there are resource implications for this. You need to mobilize health technology assessment. And the problem is, one of the problems with health technology assessment is it has to be recognized and validated at national level. But when you're a small country like Ireland, you cannot afford, I assume, to do health technology assessments on all procedures, but you need a minimum of resources at the national level where you could actually pool or rubber stamp some of the reviews that are done in other countries so that you deem them safe and valid for use in your national level. You also need to engage with professional organizations, and this is actively the case in Canada, where there is a dialogue between the government and the professionals organizations, particularly at provincial level. You need to have real-time information exchange, building training to build capacity among practitioners, and I guess with some caution, use of financial incentives. When you move away from fee-for-service payment, there are countries that are offering additional payments for GPs according to the percentage of their patients that receive certain levels of vaccinations or certain level of good practices, prevention against colon cancer, et cetera, et cetera. Now, since I was a health economist in the past and still am in some part of my brain, I thought, what kind of a message can we bring to Ireland from the OECD work? And in fact, when I looked at some of the OECD quality of care indicators that are in Health at a Glance 2025, there is a satisfactory situation for effective primary care, avoidable hospital admissions, for mammography screening, which is qualified as preventive care, and for secondary care, that is a 30-day mortality following an acute myocardial infarction or a stroke. However, there are still some gaps, and I guess you know that as well as I do in terms of antibiotics use, where your use is still twice as high as it should normally be. But you're not the only ones, because you're in good company with France, Italy, Spain, and Poland. And also, in the lower left part of the slide, you have impressive results for health screening, where breast cancer screening and health expenditure, your health spending is a little bit high, but your breast cancer screening is clearly above the average. And I also saw in the previous, because I did my homework, in the previous Health at a Glance publication from 2023, you also had relatively high COVID vaccination boosters for seniors in 2022. And here I can zoom back because I'm not so young anymore, and your minister was saying, at 45, I know the progress that we have made. I must say, at my age, I'm someone who visited this country in about 25 years ago, in 2000, and I was invited for a discussion with your minister, Michael Martin, and people were very concerned, and at that time, I had pioneered with a special huge grant from the National Institute of Health in the United States. We had developed an international comparison of healthcare systems on a disease-based approach, selecting 3 diseases: breast cancer, stroke, and AMI. We were working with David Cutler at Harvard and other American academics, and they were looking to see what we could say in terms of comparing the performance of healthcare systems using microdata, and particularly also using survival data. And that's how we discovered, for example, in the UK, that there was very low survival rates for women for cancer above the age of 65. And we were also so we had an interesting discussion with your minister at that time, and clearly, I think at that time, Ireland did not even have any breast cancer screening programs. You were just starting and discovering, of course, tumors at a very advanced stage, and the system was clearly not as structured as it is today. So I think I can testify that in 25 years, this country has made impressive progress, and I've witnessed some of that, or at least it shows up in the OECD statistics. Yes, I wanted to say one word on the role of mobilizing evidence to address the dynamics of the healthcare system, this technological progress. Because I think the way that research is funded and organized in healthcare, and the link with pharmaceuticals, large companies, they are expanding possibilities, but at an always higher marginal cost. And when I was working in the area, the Japanese were always complaining because they were trying to find ways for healthy aging at a cheaper rate, or in a way, how can you find ways to improve the health of people at a lower cost? And in fact, the problem is The role of health ministries and evidence-informed policymaking is to target the interventions or the use of pharmaceuticals or the expensive treatments where they deliver the highest improvements. The role of pharmaceutical companies on the supply side is to expand the scope of indication so you can maximize profit and apply and distribute as many drugs or interventions as you can. And there is a dilemma between what you would call technical efficiency. For example, you can be super efficient doing thousands of elective surgeries, such as appendicitis, or you can do a lot of cesarean interventions, so hospitals will be super productive, but what results does it make in terms of public health? And that's the kind of questions that I guess you have to be grasping on an everyday basis, and I guess you need constant streams of research so that you can somehow limit some of the implicit incentives that are working against you. And that's the sort of the cost-effectiveness dilemma in healthcare, where you want to promote effective use to achieve better outcomes. You need to target use and focus while preserving patient access and choice. And that's one of the challenges and the slight issues. For example, when you look at the Canadian results, if you allow me, John, that some patients in Canada feel they do not have sufficient access because the system is actually quite constrained and is not so comfortable for patients, or at least not as comfortable as the systems of the US that they just see next door. So I think that's, and where do you put the cursor and how do you put the balance is one of the hardest decisions that you need to take. To conclude, so you need a joint effort to strengthen supply and governance. You need to tune in and reinforce the various parts of the systems and build mechanisms to limit idiosyncrasies and tools, processes, and institutions. And you have many of those. Of course, as I haven't done deep dive work in the Irish evidence-informed ecosystems or health systems, I won't go further than that. And you need to adapt lessons and findings to country circumstances. And in fact, Ireland here shows impressive recent performance in terms of country size. The fact also is Ireland, if you allow me, moved also from being a relatively poor European country to one of the wealthiest European countries. As a result of additional wealth and income, people are simply demanding higher quality healthcare. And I think this kind of tensions has been quite prevalent in your domestic policy debate, from what I understand. And at the same time, you are working against a highly competitive international context, both for healthcare professionals and also technologies and pharmaceuticals. And you need to manage your trade-offs and see how you will manage your access gaps. And the example of the GP access card was, I thought, a very beautiful example in the presentations this morning. Thank you very much.